I'm Dr Louise Newson, a GP and menopause specialist, and I'm going to do this live talking about POI, premature ovarian insufficiency, and also menopause in younger women. I feel really bad to admit this, but when I was training as a doctor, as a medical student and an undergraduate and a GP actually, no one taught me about the menopause, and no one actually told me that menopause can occur in young people. Obviously I've changed that. My education is so much better. I now know a lot about the menopause. But actually, the menopause in young women is really common and also really neglected. So that's why I want to spend a bit of time about this. So if any of you know people who are younger women, which I guess all of you will be, will know somebody, it's really important that you know this, because a lot of the work I do is clearly about helping menopausal women, but it's more than that actually. It's thinking about our hormones from all ages and also the perimenopause, the time before the menopause, and trying to prepare us before we become menopausal, because in an ideal world, the menopause actually wouldn't exist, because women would have their hormones rebalanced, they'd know what was going on, and there wouldn't be all this suffering that's going on. And day on day we hear stories from women who are suffering with symptoms, but also with the health risks as well. And this is where it's really important to think about our hormones in respect to menopause in young women. So POI, premature ovarian insufficiency, what it stands for, and actually it's a menopause that occurs in women under the age of 40. When I was younger, it used to be called POF, primary ovarian failure. Now there's nothing failing about these women, and it's great that the word has been changed to insufficiency. It is what it says it is. The ovaries aren't working as well, and we know that's what happens in the menopause and perimenopause. Our ovaries don't work as well, therefore they produce less hormones. Our hormones are biologically active substances that go into the bloodstream and go all around our body and set off a whole load of cascade of reactions in our body to help it function better. So our hormones, estrogen, progesterone and testosterone, are produced by our ovaries. So if our ovaries fail at an earlier age, then we'll become menopausal at an earlier age. Also, if the ovaries are removed, so if someone has, for example, a benign condition like endometriosis, they might have their ovaries removed as part of that treatment, but then will become menopausal overnight. Some people have their ovaries damaged by drugs or by radiotherapy, for example. So I see a lot of women in my clinic who have had a cancer of their gynecological organs, so maybe their cervix or their womb, and depending on what stage and grade of that cancer, one of the treatments might have been radiotherapy. Now radiotherapy can actually affect the way the ovaries work as well, and chemotherapy, so some women who've had certain types of cancer, like a lymphoma for example, or breast cancer, might have chemotherapy that can affect the way the ovaries work, and this might be temporary, it might not be permanent. But whatever the cause, we know that the hormone levels are low. Most people who have POI, premature ovarian insufficiency, the cause is unknown. It's what we call it idiopathic, which means we basically don't know what's caused it. It can run in families. So if you ask around your family, you might find that your mother, your auntie, your grandmother, maybe older sisters and cousins had menopause at an earlier age. And if that happens, it might be that you will have an earlier menopause as well, and it's important to know that. It's really important to get the diagnosis right for many reasons actually. One reason is that no one wants suffering, no one wants to be misdiagnosed with another condition when it's related to hormones. Some people obviously want to know about their fertility. Now this is an important fact actually, because many women who have POI, it's insufficiency, it's not failure. So there are a lot of women actually who might have reduced fertility but not infertile. And actually when I talk about hormones, which is obviously one of the treatments, we do know from some studies that when people have HRT, when they've got POI, they actually have better fertility. So it's really important to know that as well. It's also important because we know from many studies that the longer a woman is without her hormones, the greater risk of diseases. And this is because our hormones work very well in our body, they're biologically active, and they reduce inflammation. So we know, and I've talked about it many times before, and I'm sure I'll talk about it many times in the future, that we know that our hormones estrogen, progesterone and testosterone are very anti-inflammatory. That means they lower risk of inflammatory diseases, like I've said. And these inflammatory diseases are really common diseases. They are cardiovascular disease, which means heart attacks and strokes, osteoporosis, type 2 diabetes, lots of different types of cancers, clinical depression, Alzheimer's disease. They're all thought to be inflammatory diseases. Even diseases like inflammatory bowel disease, some types of arthritis, even Parkinson's disease, non-alcoholic fatty liver disease, they're all associated with inflammation. So the longer a woman is without her hormones, the increased risk. And we know there's been some great research by someone called Walter Rocker from the Mayo Institute, who I've done a podcast with actually, it's worth a listen to. And he's done a lot of work looking at women who are young, under the age of 40, who have their ovaries removed, and follow them up. And he's found that there's an increased risk of all these conditions and others, including kidney disease, even schizophrenia, bipolar, even drug addiction as well can increase because our hormones are so important all over our body. And so this is why it's very important for the diagnosis to be made. Now you might be asking, how do you make the diagnosis? Well, I wish I could tell you there was a really easy test, and there isn't. The most important thing is for us as women to make the diagnosis ourselves. So for example, if you've had your ovaries removed at any age, you will be menopausal. You don't need a blood test to do that. You can tell your doctor you are menopausal and you need some treatment, or you want to consider some treatment to replace those missing hormones. Now, it's harder if you've had a hysterectomy and your ovaries have been left in, because you're not going to have any periods that will guide you whether they're becoming more infrequent or lighter or heavier or stopping. Of course, without a hysterectomy, when you've had a hysterectomy, without a womb, you're not going to have periods. How are you going to tell? We also know that when women have had a hysterectomy but their ovaries are conserved, so stay in the body, then the ovaries are more at risk of failing earlier. And that's partly because the blood supply to the ovaries in the womb is very similar, and it's thought that the blood supply can be disrupted as part of the operation. And the womb and ovaries are meant to work closely together, so without the womb, it's no surprise the ovaries can fail. So then we have to have a really low threshold for thinking, if you do get any symptoms, could they be related to my hormones? We also know, just to add more confusion and chaos if you like, that women with POI, so women who are young with an early menopause, often don't have all the typical symptoms that older people do. Now, we don't know why this is. It might be just because the body reacts differently. It might just be the studies haven't been done very well. But it's thought that women have less of the flushes and sweats, maybe more of the psychological symptoms, the muscle and joint pains, the fatigue, the headaches, the poor concentration, the low mood, the anxiety. And some studies have shown it takes on average 7 years for the diagnosis of POI to be made. And often when you look at people's records, they will have been back and forth to doctors actually more than 7 times over that period, often with other symptoms, and no one's been joining the dots. So they might have had some palpitations and gone to a cardiologist. They might have had headaches and migraines and gone to a neurologist. They might have had urinary symptoms and gone to a urologist. They might have been diagnosed with a seronegative arthropathy and gone to an arthritis specialist. They might have had dry eyes and gone to an ophthalmologist. And you can see how in medicine it becomes very piecemeal, and everyone's looking at one set of symptoms in isolation. We also in our clinic see lots of women with POI who have had multiple visits and multiple treatments for reduced fertility and gone to fertility experts. And some people think, oh, is it all the fertility treatment I had that has caused an earlier menopause? And I don't think it is actually. I think it's often these women have lower hormones anyway, maybe enough to cause periods because they're still having some hormones, they're still having periods, but not, the levels aren't high enough to actually maintain a pregnancy. And what really frustrates me, lots of things frustrate me, but one of the things that really frustrates me is in fertility clinics, they're not really screening people for POI. They're not asking enough questions and picking up these women earlier. So I've seen a lot of women who have said to me, oh, well, I've been feeling really low and really anxious and really worried and my sleep's not good because I've had multiple miscarriages. It's often because their hormone levels have been low and no one's picked it up. And if anyone is thinking about having some fertility treatments but they've got an early menopause, you can still have treatment. It's quite fine to have hormone treatment when you're going for fertility treatment as well, because the hormones we prescribe are just natural hormones, and actually that's one of the reasons that when you have natural hormones you often have a high enough level which will improve natural fertility for some women. So it's worth thinking about. So what about a blood test? What about a hormone test? Can't you just pop down to a clinic and have a test? Well, actually you can't. There aren't any saliva tests, there aren't any urine tests to diagnose POI or early menopause. Now, when you look at the guidelines, we do have guidelines for menopause care, but as many of you know, they're quite outdated now. The NICE guidance are 8 years old, the International Menopause Society guidance are 7 years old, and then we've also got something called ESHRI guidance, which is a European guidance, which is which came out in 2016, I think. So again, 7-8 years old. Now, these all say that to make the diagnosis of POI, you have to have a raised FSH level. Now, FSH is our follicular stimulating hormone, bit of a mouthful, and it's produced from our brain. And as you might know, there's lots of feedback mechanisms in our body. So if our ovaries are producing low estrogen levels, all our hormones, as you know, go into our bloodstream, they go all around our body, but our brain then monitors, oh, your estrogen level's low. So what it does is it increases the FSH level to try and say to the ovaries, need a bit more estrogen, please. So the guidelines say you have to have a raised FSH, and a raised FSH will mean that someone's menopausal. They go a bit more than that actually and say it has to be raised twice, at least 6 weeks apart, to make the diagnosis. Now, all the guidelines say slightly different levels, which can be a bit confusing, but also we need to know that not everybody will have raised FSH levels. Now, there's a few reasons for this, so let me explain to you. One is that a lot of women we see will be perimenopausal, not menopausal, which means that they will be producing some hormones, but not as high as they would have done when they were younger. But also there are times when people are perimenopausal, their hormone levels might be normal, and other times when they're low. So if I had a blood test done one afternoon when I was sort of feeling all right, it might be that I've got estrogen in my body. My blood test at that time might show my FSH to be normal. Now, 3 or 4 hours later, my natural estrogen might have dropped, and then my FSH would be raised because our hormone levels are fluctuating all the time. Then the blood test might show a raised FSH level. So we can't always do blood tests every second of every day, so they can be misleading. So if they're raised, yes, that helps. But if they're normal, it doesn't exclude a diagnosis. And over the last 7 years of running a menopause clinic, I have seen countless women who have told me that their levels are normal, therefore they've been told that they're not menopausal. And in fact, I'll tell you a story. It's quite sad, but I have lots of sad stories in my head. It was a lady I saw in my clinic when I first opened. I was working on my own, just renting a room in a local hospital. And she was a 36-year-old lady, and she was actually a psychotherapist, and really lovely, really clever. And she had a family history of POI, so lots of people in her family had menopause in their 30s. And she didn't have any night sweats, but she said she had horrible sweats in the day, and in fact she was drenching with sweat every morning. She came out the shower and she had to go back into the shower to have another shower because she was so sweaty. And she said this went on every morning. She used to have 3 or 4 showers. She said, I'm very lucky, Dr. Newson, because I can choose my hours of work. Because I'm a psychotherapist, I can choose the time I have my clients. So I don't start my work till 11 in the morning, because there's no way anyone could see me before, because I'm literally drenched in sweat. She said, I have longer time with my clients than I used to, because I can't remember a lot of what they say. It takes me a long time to write up their notes and everything. It's really, really difficult. She said, I've been back and forth to the doctor for the last 2.5 years, and she brought me the results, and I put it in a graph. Actually, I sometimes use it for teaching. And she had one result where the FSH level was high. She went back 8 weeks later, because that's what the guidelines say, more than 6 weeks apart, and it was a normal level. So the doctor said, no, you haven't got POI. It must be something else. So she thought, well, there's no point going back to the doctor because I don't know what they can do to me. A year later, she went back and said, I'm really struggling. They did a blood test. The FSH was normal. They said, no, can't be that. And she carried on. And then she went back to a different doctor because she moved house. And the level was borderline. It was slightly high. And they said, oh, it might be, but actually I don't think so because you're too young to be menopausal, and left her. So when I saw her, I said to her, well, I don't know. The guidelines say this, but actually looking at you and hearing your story, your periods have become very irregular as well. I think you probably have got a hormone deficiency, and what I'll do, like we do a lot of times in medicine, is give you what we call a therapeutic trial. So I'll give you some hormones and see if you respond. Come back to the clinic in 3 months' time and I'll see how you are. So she came into the room and she looked really different 3 months later, a lot more positive, a lot more sprightly, just looked happier in herself. And I do a questionnaire, symptom questionnaire, like the one you can download from Balance app. And a lot of her tics that were right on the right, because she was having quite severe symptoms, had moved across. And so she was having less symptoms. And I said, this is amazing. Are you feeling better? She said, yes. And then she burst into tears. And I thought, oh dear, what have I done? I've upset her. And she said, Dr. Newson, I don't know what to say. I'm just so sad for the years of my life that I've missed. The years of my life where I could have felt like this. And I never realised how good I could feel, and I can't thank you enough. Isn't that wonderful? But isn't it sad that she had so many years of suffering? And this is why we need to pick it up earlier. The other thing that worries me about the blood tests is that some people can have low FSH levels, and if the levels are low, it almost switches off the ovaries, because if the levels are low, it's almost like your brain saying to your ovaries, I've got enough estrogen, thanks very much, you don't need to produce any more. And there are some drugs that switch off FSH level. One of the commoner drugs are drugs that are used for bipolar, and some types of depression can switch off our FSH levels in our brain. So we see people in the clinic who've been given a drug such as quetiapine, which is like a stronger psychiatric medication. And a lot of the thyroid can be affected in the brain. But actually, the FSH can be affected as well, this follicular stimulating hormone. So we can't always be reliant on a blood test. And just finally about blood tests, the first thing I learned as an undergraduate when I was at medical school is, Louise, look at the patient, not the numbers. And that's really important with everything that we do. We shouldn't just be looking at the numbers when someone has had a blood test. And that's the same with everything. If someone has a cholesterol blood test, if they have an iron level blood test, all blood tests, we need to look in context with the patient so we can work out. And sometimes if we're not sure about a blood test result, we will repeat it, of course. But often it's assessing how people respond with treatment. So this lady, I thought she had a good history. She had lots of symptoms to suggest an earlier menopause. And indeed, I gave her some hormones and she felt completely better. So the story's quite obvious. Now, what is the treatment? Well, once we've made the diagnosis, then we need to be thinking about treatment. And it's very important, and the guidelines do concur here, that women should be considered for hormones unless there's a reason that they really don't want them or they really can't have them. So I'm talking as a generalisation here, but certainly for the vast majority of women with POI, we should be offering and thinking about hormones. And that's main reason actually is because of the health risks associated to being young and having menopause. Of course, when people have symptoms, none of us want to listen to people suffering, and so having the right dose and type of hormones will reduce symptoms and should stop symptoms actually if you get the right dose and type right. But more importantly, I've already said there are these health risks associated with young women having an earlier menopause. And so all we're trying to do as clinicians is to replace the missing hormones so that women's bodies can function properly. I've already said that estrogen, progesterone and testosterone, our so-called sex hormones, are more than just hormones that regulate our periods or fertility. They are biologically active all around our body, but especially in our brains, in our cardiovascular system, in our kidneys, in our muscles, in our joints, everywhere. And we know that without these hormones, we get this accelerated aging, we get this increased risk of inflammatory diseases. And of course, people should be looking at their lifestyle, their diet, but actually it's really crucially important they have those hormones back. If someone was young and had their thyroid gland removed, you wouldn't just say, oh, carry on and see how you feel. So anybody who's planning on having their ovaries removed, part of the treatment should be to have this conversation before surgery. What about having my hormones back? And you should be talking to your consultant before the operation. Every day in the clinic, we hear from women who were told by a gynecologist, see how you get on without your hormones, don't worry about it. Well, we should be worrying about it because of this increased risk of diseases. And so it's crucial that the conversation starts early. Of course, if you're not going to have your ovaries removed, but you have an early menopause for other reasons, like I've explained, it can be very difficult. But once the diagnosis has been made that hormone levels are reduced, then we should be talking about getting the right dose and type of hormones. Now, estrogen, like I've already said, is best given through the skin as a patch or gel, and then it goes straight into the bloodstream all around the body. Just it's the natural body identical hormones, so very, very safe. If a woman's still got their womb, we should be giving progesterone to protect the lining of the womb from the effects of estrogen. But also progesterone is a very important hormone in its own right. It's very anti-inflammatory, it's very good on our brains. So there are some women, even when they've had a hysterectomy, who do benefit from a progesterone. So that's worth speaking to your menopause specialist about. And then the other hormone, which has been neglected for far too long, is testosterone. And many women, especially when they have their ovaries removed or they're menopausal at a young age, do actually miss testosterone. The guidelines do say that we can consider testosterone if women have reduced sexual desire despite taking HRT. But we find, and so do many others who run clinics, that it's not just about libido, that mood, energy, concentration and stamina, sleep, joint pains, muscle aches can improve with testosterone because it's a biologically active hormone that works all around our body. And many people find that they miss it more. With testosterone, levels of testosterone just decline with age. So a 20-year-old will have higher levels in general than a 40-year-old. And so if a woman becomes menopausal at 30, for example, then their testosterone level will be lower quite often. So it's important to consider all hormones, and a lot of people we see on the clinic have said, well, it's not related to my hormones because I'm on HRT. And then you look at their the dose that they're on, and they might be on a 25 microgram patch or a 50 microgram patch, which is really, really low actually for someone of that age. And this is really important that we get the right dose for women. We do sometimes do blood tests, and I've talked about blood tests before. Blood tests for hormones, for estrogen, aren't very useful always to make a diagnosis because the levels can vary, but they can be quite useful to monitor treatment, because if someone, for example, saw me in the clinic and they were on a 50 microgram patch and they were still having some tiredness, some memory problems, some joint aches, maybe some low mood, I would do their estrogen level, and if it's low, it will be an indication to me that we can increase the dose. Some people do need higher than licensed doses, and I've spoken about why that might happen before, but we know that our skin is a barrier. Our skin is not designed to have drugs going through it. And some people, just the skin type is different, so then they need a higher dose to get the same amount through the skin. But there are also a lot of women who are young who just need a higher amount in their body, and that's because physiologically they're designed to have a higher amount in their body and they can respond better. And so we spend a lot of time in the clinic deciding on the right dose for that individual. And I always say to women, let's just try and replace your hormones in a physiological way, replace what's missing, and then we can see how you are going forwards. And so some people might be fine on maybe 3 or 4 pumps, or 75 or 100 microgram patch. Other people will be better on a higher dose. And it's not, when we measure the blood test, it's only what's in the blood. It's not what's in the tissues, it's not what's in the brain, and it can really vary. The other thing, often with women, especially when they're young and perimenopausal, with time their own hormones will decline more. So you might find you're started on one dose, and this is why it's really important to have a regular review with a clinician, because you might find on your review that you need a slightly different dose because your own hormones have declined, so the deficit, if you like, is more. So you might find that the dose does need to be increased. And quite commonly in the clinic we see people and they say, oh, I felt great initially and now I'm all back to where I was. I don't think the hormones are working. And it's usually not they're not working, it's just the dose needs changing. And that's really important actually. And changing the dose or the type of HRT might make a real difference. And if people are still getting symptoms, then we also consider testosterone as well, and making sure they're on the right type of testosterone and the right dose. So that's really important. The guidelines also often say that we should have a DEXA scan, a bone density scan, in women who have early menopause under the age of 40. And that's because I've already said osteoporosis is very common. It affects 1 in 2 women who are menopausal. And I've already said the longer we are without our hormones, the greater the risk of osteoporosis. Now, thankfully, HRT is actually a treatment for osteoporosis, and it has been shown to reduce the incidence of osteoporosis. So it's useful to know that, but it's also really useful to know what our bone density is. So the guidelines say we should have a DEXA scan. We should also look at thyroid function, especially in people who have idiopathic POI, so when we don't know the cause, because sometimes it can be associated with autoimmune conditions. And autoimmune basically just means the body has built up antibodies against itself. And there are other autoimmune conditions that can go hand in hand in some people or some families. So type 1 diabetes, thyroid disorders, some types of arthritis, celiac disease as well, which is when people are very sensitive to gluten. So often as a baseline, if someone comes with a new diagnosis, we will do their thyroid test and include some autoantibodies to look for autoimmune diseases associated with thyroid. We'll often do a test for celiac disease as well. And then we often check their sugar level. We usually do the HbA1c, which is like your average sugar level over the last 6 weeks or so, just to make sure that you haven't got diabetes. And also we often do things like blood pressure, cholesterol as well, making sure that your cardiovascular risk, so risk for cardiovascular disease, is as low as possible. Once hormones are balanced, then of course we look at the whole lifestyle and nutrition and weight and everything else as well, because what you want to do is be as healthy as possible to reduce your risk of diseases, and it's often doing everything together. But we know when people take HRT of whatever type actually when they're young, because we're just replacing the missing hormones, there's no increased risk of anything, no increased risk of breast cancer at all, which is very reassuring. Now, some people might say, well, why don't I just go on the pill because I'm in my 20s or 30s and all my friends are on the contraceptive pill. Why don't I go on that? Well, of course you can. Anyone can do anything within reason, and it's important to talk about choices, especially with your clinician. Now, there's a few things just to tell you about the contraceptive pill which you may or may not know. Firstly, the contraceptive pill, whichever type, whether it's the combination oral contraceptive or whether it's the progesterone-only pill or the implant or the injectable progestogen, they're all synthetic, so they're all man-made and they're not the same structure as our own hormones. They've been chemically modified, and that's okay, but we know there are very small risks with this. Now, the risks are low, but they're still there. So there is a very small increased risk of heart disease, a small increased risk of raised blood pressure, a small increased risk of colorectal stroke in all these synthetic hormones. It's only very low, but actually when women start on hormones for POI, they will take them till at least the age of 51, the average age of the menopause, but usually they take them beyond that as well, because we know for most women we can take hormones forever as long as the benefits outweigh the risks, which they usually do for most people. So actually, we want to often start a treatment that we're more likely to continue as well, because if you start a contraception, we know that we have to stop it and change to hormones at a future age. The other thing with the combined oral contraceptive pill, a lot of people take it for 3 out of 4 weeks, and in that 4th week is when they have a withdrawal or bleed, so a period. Now, if you're only taking hormones for 3 out of 4 weeks, actually in that 4th week you won't have any hormones if you've got POI, so it means you're only giving yourself hormones for 75% of the time, which isn't ideal. There has been a big move to run the pill packets back to back regardless of what you're using it for. So even for contraception, usually we recommend to not have a break, actually to keep going, because we don't have to have this withdrawal bleed every month, but that's again an individual choice. But even if you run your packets together, firstly, like I say, there's very small risks, but secondly, we don't know what the long-term benefits are for these synthetic hormones. With a combination or a contraceptive pill, it contains estrogen and a progestogen. Now, most types of the estrogen are synthetic, so they're not as natural as what the normal estrogen is. And so we know from studies it's probably not going to be as good for bones, for heart, for reducing risk of dementia, reducing risk of type 2 diabetes, clinical depression and so forth. If you've got a choice of having a natural hormone or something synthetic, then actually it just makes common sense to have the natural hormone. So that can be more of a benefit as well. The other thing with the combination oral contraceptive pill is that because it's taken orally, the estrogen, it does something to what's called our sex hormone binding globulin, which actually binds our testosterone, and it increases the amount of this SHBG, it's called, sex hormone binding globulin. And so it means we have less freely available testosterone in our body when we take the contraceptive pill. And some women really notice this reduction in freely available testosterone. It might be manifest by reduced libido, but also by low mood, reduced energy, poor concentration, just feeling a bit can't be bothered to do things. And often we blame it, don't we, on young people say, oh, it's just their attitude, you know, it's just the way that they are. Is it the way they are, or is it because their natural testosterone's been blocked? And we know that, don't we? With lots of contraceptive pills, people go through 3 or 4 different types, and then they might find one that really suits them, because all the synthetic hormones are slightly different and they work slightly different in the body. And that's why we need to be thinking beyond just contraception for women. We need to be thinking about how's it affecting them as individuals. Now, if we think about the progesterone-only pills, what they do is they're blocking ovulation. They're stopping ovulation because obviously they're stopping fertility. Now, if they're stopping ovulation, of course, they're blocking estrogen and testosterone as well. It's almost like having a bit of a chemical menopause. And I never really thought about this when I was younger, but it's very obvious when you think about it. If you're blocking fertility, you're blocking hormones. And of course, we've known for a while, actually, people who were on the injection of progesterone did have or do have a small increased risk of osteoporosis. And I remember when the study came out many years, about 20 years ago, I was thinking, well, what else is it having effect on our body? Why is this? And that's the whole thing. You probably know I've got quite an inquisitive mind and I want to know the answer. And so when I read this study, I was thinking, well, what must it be caused by? Of course, it's due to the low estrogen because it's suppressing our hormones. And so if someone's got POI, the last thing they want to do is to suppress their hormones even more. So we tend not to recommend the progesterone-only pill or the implants. If someone's having heavy periods, because heavy periods can occur in the perimenopause as well, then we often recommend a Mirena coil. Which a Mirena coil does contain a synthetic progesterone, but it's only a very, very low dose. It works on the lining of the womb to keep it thin, and it can be brilliant for many women for many reasons actually. Firstly, it stops periods. How wonderful to not have periods. Secondly, it's a really good contraception, which is great. And thirdly, it can be used as part of HRT. So that's the progesterone part to protect the lining of the womb. But of course, then people still need estrogen, often need testosterone, and may need progesterone as well for the systemic effects of progesterone. I speak to a lot of women who say, oh, I'm on HRT, but when you talk to them, they're only using a Mirena coil, but that's not having the systemic hormones, so we need to think about that. And then before I finish, there are women who have POI who have genitourinary symptoms, so they have symptoms of irritability of their bladder. They might have recurrent urinary tract infections. They might have recurrent thrush. They might have pain on intercourse. It might just be uncomfortable sitting down. They might have an increased discharge rather than just feeling dry. Whether they take HRT or not, these symptoms can still be very common. And so one of the treatments for that is having vaginal hormones, and there are different vaginal hormonal preparations. Most of them contain estrogen, and they can come as a vaginal pessary, a vaginal tablet, a vaginal ring, a vaginal creams and gels. And there's also something called prasterone. In the UK we call it Intrarosa, which is a daily vaginal pessary which contains DHEA, which converts to estrogen and testosterone. And people using systemic hormones can still use the vaginal hormones as well. So it's really important that women aren't neglected and thought about just systemically for treatment, and think locally as well. So it's important to get the right advice, the right treatment, and looking long term as well. It's not just a short term fix when people have got POI or an early menopause. Making sure you have a good relationship with your healthcare professional so you can review and get the right treatment that might need tweaking and adjusting, and see your healthcare professional at least every year as well. So I hope that's been really helpful. Thank you for joining on a Monday night. I'm going to go back and do them on a Sunday at 6 because I think that's quite a good time to do them. If you don't think it's a good time or want a different time, of course put them in the comments when I post this on my grid. And I hope that you're enjoying having these Instagram lives. If you want future ones, let me know. I was thinking next week that I would do one on genitourinary syndrome of the menopause, bit of a mouthful, GSM. Used to be called vulvovaginal atrophy, but none of us like that term because atrophy is something none of us want to do. We don't want to wither and waste away. So I'm going to do about that because it's very, very common. So that will be the next topic on Sunday at 6 o'clock. And then if you want future topics, just put in comments below when this is posted, and let me know. So thanks for your time and enjoy the rest of your evening.